It's nice to be here and to talk to all of you. It's a bit of a dubious distinction, though, because this is the last talk of the day and you're probably all exhausted, and I also stand between you and some fine Belgian beer, so I'll do my best to get through the talk in a reasonable period. One thing you'll notice, there's my email. It's on your program. Please write it down. One of the best things that we do at the IPOKRaTES program is to have people write us emails and ask us questions after the meetings are over. That keeps the dialogue going, and we all have a lot of fun. So I'm going to talk about hypoglycemia. This is a problem that has been identified for many, many years as unresolved, and unfortunately, there has been little progress in resolving it. Largely, this is because there is a lack of data, so most of the things that I'll talk to you about are irrational, meaning people may have their opinions, but they don't have a lot of data to back it up. Just to make it clear, unfortunately, untoward long-term outcomes of infants with 1 or 2 low blood glucose concentrations have become the grounds for litigation, and that's a problem that is unfortunately not unique to the United States. Along with Burger King and the other fast food items, we've transported this all around the world, and I apologize sincerely for that. That does not mean that those attorneys and families who have children with brain injury that could have been the result of low glucose concentrations are without cause. It is fundamental that your brain doesn't work if you don't have energy, and the main energy supply is glucose. So do not ever get me wrong. While I may say that some of the issues around neonatal hypoglycemia are very inaccurate and poorly portrayed in the literature based on opinion and not fact, glucose is essential. The other problem that we have is in terms of lack of data, is that we have no significant or no realistic definition of what this condition ought to be, and I'll go through all of that. So, when did people start looking at hypoglycemia by measuring blood glucose concentrations? This actually started in the very early part of the last century with the advent of measuring glucose concentrations using the glucose oxidase technique and the Samogi method. But the first real data were published in about 1937. That was in Europe. They defined a group of infants, and these were not that many neonates in this group, of having mild, that's 40 to 50 milligrams, so you can translate that into a couple of millimoles per liter, moderate 20 to 40, and extreme less than 20. 20 would be about 1 millimolar. So how many of you would say that those are reasonable guidelines? Don't most of us say that extreme hypoglycemia is less than 1 millimolar, and moderate is a little bit above that, and mild is not quite into what we call the normal range, above 50 to 60 milligrams per deciliter, 3 to millimolar? I mean, this is something that we've now had since 1937, and we still use almost exactly the same criteria. Over the first half of the last century, really not that many neonates were observed to have low glucoses. The ones that were observed all had clinical signs. They were symptomatic, which is how they came to attention and had the blood sugars measured. Most of these were episodes of tremors, irritability alternating with lethargy and hypotonia, so an unstable neurological exam that was reasonably obvious. They had apnea and cyanotic spells when they were quite severe. They fed poorly after initially feeding well. They may have lost some body temperature, and their changes in level of consciousness could, when severe, proceed to having seizures and falling into coma. I have actually witnessed one baby go through all of this because there was an inadvertent mistake where a nurse took the baby's IV in flush solution that had heparin in it, mistakenly took the one from the baby next door that had severe hyperglycemia, and that bottle, which looked identical, had insulin in it, and repeatedly flushed that baby's line with insulin. And I didn't know why this baby was progressively going through every single one of these conditions, but it was absolutely classical. So that is the pattern that you will see as hypoglycemia progresses to a very serious condition. All of these had low glucose concentrations in the CSF. Realistically, though, these babies did not have long-term adverse outcomes neurodevelopmentally, and that's always encouraging, although I wouldn't want you to say that they were perfectly normal. That's different from doing an exam. And most of these infants that had problems long-term, they weren't separable from being growth-restricted, small for gestational age, or having other problems such as maternal toxemia, preeclampsia, that cause probably some intermittent hypoxemia to those fetuses and that led to long-term developmental outcomes. Interestingly, symptoms regress or disappear when the glucose concentration is corrected. That's the only way that I could ever say that low glucose is causing the symptoms, because these symptoms, what we look at and what we see, are found in almost every kind of illness that babies have. So as a result of these surveys, the consensus was somewhere later in the last century that even extremely low glucose concentrations, less than 1 millimolar, less than a half a millimolar at times, were of no or only minimal significance since they occurred with and without clinical manifestations. They usually were transient, minutes to an hour or two, were easily corrected, and the signs, the symptoms disappeared with correction, and they were not associated with long-term outcome deficits that were separable from other medical problems that the babies had. And then along come some other people, and basically these were the endocrinologists, and there's no reason to dump on endocrinologists. They had a strong reason why they wanted to have the threshold glucose concentration for what we called hypoglycemia and to intervene and correct lower glucoses, because they see problems with babies that have metabolic disorders and other kinds of conditions. So, sort of by fiat, one of these endocrinologists, a good colleague and friend of mine in Philadelphia, published an article in the New England Journal of Medicine saying all newborn infants of any gestational age and any postnatal age should have a glucose concentration above 60 milligrams per deciliter. This didn't go over well with neonatologists, because that would have meant that every single baby who was breastfed would have had to have had an IV, and that's nonsense. So we had a disconnect between endocrinologists who were seeing babies with severe problems and those of us who see transient hypoglycemia, treat it as a routine issue, take care of it with normal measures, and don't get terribly excited about it. We still have to come to some common ground to resolve these issues. To date, though, there's been no demonstrable study to say the endocrinologists have the upper hand on this, and laboratory studies don't support this, because there have been lots of animal studies showing that you really have to have glucose that's very low for a long time, hours, not minutes, and that there must be a loss of electrical activity, or at least a reasonably isoelectric EEG for at least a couple of hours before you start seeing progressive neuronal loss, and that's neuronal loss, not apoptosis, neuronal loss from cell death. No one's going to do that kind of a study. So why such a high threshold? Well, there are babies that have genetic disorders where insulin is produced in excessive amounts, and it's unrelenting, and it drops the glucose almost no matter what you do to zero, produces seizures, coma, and brain damage. It's clear, and it's been recapitulated in animal models. No point in saying that that is not a serious disorder. And that's what the endocrinologists see. They're the ones that get the baby who's 2 or 3 weeks old, who comes back to the emergency room in the middle of the night, having not fed well for hours, and comes in with seizures and coma. That's the problem. Similarly, there are babies with fatty acid oxidation disorders who, because they can't use fatty acids for energy production, use up all of their glucose. Their liver can't keep up with glucose production, they don't feed well, all of a sudden their glucose falls to zero, and they have cardiac arrest They many times die, even in care situations in the hospital. And then there are babies with hypopituitarism. Can't produce the hormones that are regulating glucose production. They are going to have serious problems with low glucose. All of those infants are seen by the endocrinologists, and they're the ones that see them after the baby's had a problem. Problem so severe that they either died or had brain damage. So you can understand why one group is going to be very interested in making sure that the neonatologists and pediatricians don't miss low glucose concentrations or send a baby home. I'll come back to that later on. So over time, as a result of this kind of conflict, we've had a never-ending series of increases in the threshold glucose concentration that we'd call hypoglycemia, and anything below that value, we ought to do something about it. So that's based on the Hartman and Jordan data. And then along came people like myself early in my career. I didn't know any better, and a bunch of us started saying, well, we don't want to get to this value because that's really low. So let's say we ought to have it a little higher, and we just picked a value. There's absolutely no data to support that choice. And then we just started, a little later on, another group came along and said, well, they said we ought to be at about this value. We don't want to get to that value, so we're going to make it a little higher. And here comes the endocrinologists who say, we don't want to mess with any of those lower values. Let's take 60. Nothing in terms of data to support any one of these choices, and there has been no change in the incidence of low glucose concentrations as we have seen this threshold value arbitrarily increased. Here's data from the literature, and by the literature I just use textbooks because obviously by now, since 1937, we ought to have established in the textbooks some authoritative statements. There's Charlie Stanley's value of 70. He even got it up to 100 milligrams per deciliter. Here's Satish Kalhan, 36. Why 36? That's 2 millimolar, okay? Why? Who knows? I've asked him many times, and he doesn't have an answer. Ed Ogata put less than 40, and Jane McGowan and I we went with Satish for the lower value, but then I went back to my value that I started writing about when I was junior faculty and had no data for because I liked it. So you can see the literature is full of nonsense. They're all reasonable choices, but there's no data to back it up. Let's start going through what the problems are. Why is this an issue clinically? Well, I've shown you some data about, or some descriptions of babies that have symptoms, but lots of babies have similar symptoms. Why are they variable? That's because they're nonspecific. We see them in all kinds of disorders. There are alternative substrates present and in varying amounts that can lead to energy balance in the brain. If they're there, and if not, they may allow hypoglycemia to produce symptoms. There are short and long-term adaptations, and then there's large changes in physiology. A very high cardiac output due to adrenaline in response to low glucose is going to increase cerebral plasma flow and provide glucose by faster rates of delivery, even though the concentration is lower. So you could imagine all kinds of changes in cerebral glucose delivery that are dependent on cardiac output, plasma blood flow, and cerebral perfusion. And I could go on and on about that. The hematocrit dilutes blood the glucose in the blood, also dilutes it in the plasma. But streaming that you get in small vessels when you have a higher hematocrit puts the plasma on the outside and the red cells in the middle. So even a higher hematocrit that's diluting the blood of glucose is allowing still increased delivery. We could go on and on. Here's data on ketones versus gestational age. Very small babies don't have a lot of fat, so they can't produce ketones. As you get bigger, you can get higher ketone concentrations. If you take the average baby on day one, though, they don't have high ketone concentrations. Even those who are being breastfed, and everybody says it's the breastfed babies that are going to have high ketones, well, you just don't find it that often. So highly variable, even among normal infants. Why is glucose supply to the brain important? Well, because we're humans and we want to have a good brain. And brain glucose uptake rates in neonates are extremely high. There's the data. This will be on your exam tomorrow morning. You didn't know you were having an exam? Okay. 4 to 5 milligrams per minute per kilo of body weight. In other words, most of glucose production in a normal baby goes to the brain for its utilization. Small amount goes to the heart, along with lactate, because that's what the heart used as a fetus, gradually substituting fatty acids as the baby progresses postnatally. And then I mentioned the alternative substrate. So that's a lot of glucose. This is a cardiac condition. That's survival time. That's cardiac carbohydrate, meaning if you're anoxic or hypoxic, or you're undergoing hypothermia, the more cardiac glycogen you stored or still have, the longer you're going to survive when you have these adverse conditions. There are lots of these kinds of old studies that look at different organs. That was just one that, well, we think the heart's kind of important too. Here's the brain. That's man. This is ratio of brain weight to body weight. And compared to rats, cats, rabbits, guinea pigs, pigs, and sheep, even in the neonates, that's the, in the adults, but particularly so in the neonates, the brain to body weight ratio, the brain to liver weight ratio, so the brain to the organ that can produce glucose ratio is extremely high. And it's excessively high in humans compared to other animals because they have smaller brains to start with. Actually, when you measure animal non-human brain glucose metabolic rates, they're not too different. So it's the size of the brain that's per body weight that's critical. Then there are follow-up studies which suggest that hypoglycemia, not sufficient amounts of glucose for brain metabolism, might be associated with problems. So here's a study by Koivisto. He studied infants that had so-called hypoglycemia. He defined it as I forget the exact value, but just say low. And he followed them up 1 to 4 years later. And among those infants with neurological deficits plus seizures, so they were clearly neurologically abnormal when they had hypoglycemia. So this is the really severe group. 30-some% were normal and 50% were abnormal. Well, it's reassuring that about 1/3 of them were normal. That's good news. But that's a lot that were abnormal. Of those with neurologic deficits but no seizures, now 76% were normal. 3/4 of them were normal, and only about 10 to 12% were abnormal. So obviously what's changed in those two conditions is the presence of a seizure. If your glucose goes down and there's nothing else wrong with you except the low glucose, but it gets so low that you have a seizure, you're probably in trouble. And that's what we'd like to prevent. And among those with no neurological deficits, just low glucose concentrations, and they could be symptomatic but not having neurological deficits, then almost all of them were normal, but there still were a few that were abnormal. So it still is an issue that very low glucoses can show up as contributing or at least associated with long-term adverse outcomes. Now, I promised I would not get into basic science chemistry. I just want you to be sure that you understand that I could put hypoxic injury or severe oxygen deficit here, and you would see pretty much the same pathway, where glutamate uptake across the neurons, across the neuronal connections is reduced. You have buildup of glutamate, receptor activity is increased. You have, from the loss of energy production, decreased ATP. ATP-dependent ion transport is diminished. You get increased sodium and calcium entry into cells. They swell, they die. There's loss of membrane potential, and so forth. Why we see glucose deprivation in animal models affecting parts of the brain but not the entire brain, or not the parts of the brain that are affected by low oxygen, still hasn't been sorted out, because it's basically a very similar pathway. So why do we focus on glucose concentration? Clearly, glucose is an important issue, but why plasma or blood concentration? That's because we can't really measure brain blood flow and therefore glucose delivery to the brain. We can do that in an animal model We could even do it in humans under very carefully controlled research studies, but you don't do it as a bedside technique. We can't measure brain glucose uptake except in experimental situations, and that's what we would really like to know. Regardless of the concentration in the plasma, we want to know how the brain cells are doing with respect to getting glucose into them. Brain glucose uptake is dependent, at least in the low to normal range, on plasma glucose concentration. Saturation occurs above that, but if your glucose is low and you raise it, you can expect to see an increase in delivery of glucose from the plasma into brain and into brain cells. Unfortunately, the problem is the correlation between plasma glucose concentration and the consequences of insufficient glucose supply to the brain are all over the map. They're very poorly put together. So, given all of that, why should we define neonatal hypoglycemia? It's been a problem defining it all along. We should, because all symptoms seem to go away when you give glucose if glucose was the problem causing the symptoms. So that becomes diagnostic, and I think that's highly valuable. That would help you sort out whether that baby might have persistent hypoglycemia causing symptoms and be one of those babies you'd want to have the endocrinologist help you with sooner rather than later. And then we have these organic causes that I mentioned. So we have hyperinsulinism, hypopituitism, metabolic blocks. So there is reason to know about when a glucose concentration is possibly too low. And there's this observational evidence, and I'll just go through this again. Symptomatic hypoglycemic infants, especially those with severe, protracted, recurrent problems with neurological problems of seizures, progressing to coma, very low glucoses, lasting for several hours or more, they have a poorer prognosis. The worse those conditions are, the longer they last, the more they are recurrent, the less likely you are to have normal neurological outcomes. Cerebral palsy is a major issue in that case, even to mental retardation. Prognosis is difficult to ascertain based on all of that because follow-up data are limited. They're hard to get, and they're often retrospective. It's difficult to choose controls. We don't have infants with low glucoses that don't have symptoms that we don't or do treat. We don't do that to babies. We either treat them or we don't study, or we think they're normal. When hypoglycemia is part of an underlying process, it's often difficult to distinguish whether the outcomes are from hypoglycemia or from the associated condition. And then I already mentioned that acute hypoglycemia in animals, including in fetal studies, does not reduce brain glucose levels or utilization rates. That's because there are alternative substrates that are available, and those are, as I said, are very highly variable. So then, look at the other side of it. Why should we not define hypoglycemia? Well, that's simply because we lack the data. No prospective study has ever been done that has really said, if you keep a baby at this low glucose value for this duration, with this set of symptoms, with or without correcting it, you'll develop a certain outcome. That kind of study simply hasn't been done in any group of infants. And I don't think it will, for probably at least ethical reasons and also some fairly complicated technical reasons. As I just mentioned, it's pretty tough to measure at the bedside brain glucose uptake and associate that with neurological conditioning. So this is the definition that I used, and that means there is no definition. The absolute blood or plasma glucose concentration that defines hypoglycemia in newborn infants remains difficult to establish and has not been determined. There's no consensus about threshold glucose concentrations for diagnosis or treatment. This is because there's no absolute correlation between blood or plasma glucose concentrations, clinical signs or symptoms, and either short or long-term sequelae. So I think I've made the point. So along comes another group and says, okay, we don't know, so let's pick some values that we might show active thought and potential intervention. This was the operational threshold paper that was published in Pediatrics now quite a few years ago. Asymptomatic infants, they picked a threshold of 46. Symptomatic infants, 36. High-risk infants, the same. This is 2.5 to 2 millimolar. The operational threshold is to be distinguished from the treatment target. You want a treatment target to be higher than the operational threshold. The operational threshold is merely the value below which you need to consider whether there's something needs to be done or not. What you do, of course, is going to be highly variable. The concentration at which organ damage occurs, particularly the brain, was not part of this evaluation because they didn't know either. So this is just yet one more set of opinions because this was not based on anything other than looking at other people's writings in the literature, which we've already said don't have much to show. So I took another point of view. This is the normal fetus. This is the normal human fetus. This is data from Anna Maria Marconi and her group in Milan. 16 weeks gestation up through 42 weeks. These are umbilical vein blood glucose concentrations obtained by umbilical vein sampling, which was done for either genetic or rule out infectious disease issues. If they didn't find a problem and the baby delivered at term and was normal and healthy, they could say, okay, these represent values from normally growing fetuses. And you can see that there was never a glucose concentration below 2.8 millimolar, about 50 milligrams per deciliter, among all of these different babies. That's an awful lot of data from human fetuses. If you then look at normal human infants after birth, this is what happens. Their glucose concentration is highly variable depending on mother's glucose concentration primarily. It falls after birth, the umbilical cord is severed, and the baby now has to start producing its glucose, which it does after 1 to 2 hours almost invariably. And by around 2 to 3 hours, the glucose concentration exceeds 30 milligrams per deciliter, 1.5 millimolar. By 3 hours or to 7 hours, or to 8 to 10 hours, it gets up to around 2.5 millimolar. And by somewhere around the end of the first day to the second day, it's almost always consistently above that same value of 2.8 millimolar or 50 milligrams per deciliter. So if you just look at observational data of normal human fetuses and normal human newborn infants, if you said what's a lower value for the normal range of glucose concentrations, I would pick 2.8 millimolar, 50 milligrams per deciliter. If there's any lawyers in the audience, that does not mean that if a baby has a glucose below that value, that the baby is invariably brain damaged. It simply says that this is the normal range. So you heard it, there it is. Fits very nicely. At about the same time those sorts of studies were being done, Alan Lucas at the University of Cambridge did this study where he had babies, these were preterm infants, and there were 5 groups, each fed different kinds of food, from very dilute banked milk bank milk that was very dilute in nutrients to enriched preterm formula or enriched supplemented human milk. And what he showed was that when they measured glucose concentrations in those babies as part of this study, the more often they had low glucose concentrations, less than 2.6 millimolar, almost the same values, that 2.8 millimolar, they showed increasing deficits in both mental and motor developmental outcomes. Now, this has been a severely criticized retrospective study, but I still consider it about the only good study out there that said, could there be? Didn't say there was, it said, could there be a problem with your baby having more and more lower glucose concentrations? Well, it could just as easily have been that these babies were not normal, and the more abnormal they were, the less capable they were of regulating glucose concentrations. So low glucose concentrations and the neurodevelopmental adverse outcomes were merely markers for the previous, whatever the underlying condition was. Nevertheless, it certainly fits with what normal babies and normal fetuses have for their lower glucose concentrations. Now, the reason that study by Lucas is also suspect is that the exact same study was done by another fellow. This is by a group headed by Win Tin in Northern UK Nursing Initiative Trial. So a very similar population of babies. in a very similar environment, northern England. And each one of these sets of bars represents a different neurological evaluation. The turquoise bar is the index case. This is the control case. The index case were those babies with low glucoses, less than 2.6 millimolar on frequent occasions. So a very similar observational study that Lucas did, and they found no differences, as you can see by those bar graphs, in the neurological outcomes. So the same study repeated in another part of England didn't come up with that declining observational motor and mental development. So it leaves it up in the air. Could there be some responses that happen in all kinds of cells and organisms to low glucose? If you take a cell and you grow it in a lower glucose concentration, it does just what animals do. So these are rats, these are rat fetuses, and they maintain, or in some cases actually upregulate cell membrane glucose transporters, which those are the molecular transporters that get glucose from plasma or extracellular fluid into a cell. So here's brain tissue and glial cells. Here's your, and this is densitometry of GLUT1, the ubiquitous glucose transporter. The lung and fibroblasts, they're not too important, so they could get hypoglycemic, I guess. But the brain seems to maintain its glucose transporter concentration despite low plasma glucose concentrations. These animals were IUGR, growth-restricted fetuses, and they had low glucose concentrations, about 30 to 40% less than normal. So that's a chronic condition, and it shows an upregulation of the glucose transporters, or at least a maintenance of glucose transporters in the presence of low glucose concentrations. Here's another study in rats. Each one of these represents an area of the brain, and when you make this animal hypoglycemic acutely, the metabolic rate for glucose in that area of the brain falls significantly. But if you keep that animal low in its glucose concentration, over a few hours to a day or two, the cerebral metabolic rate for glucose in all of those brain regions returns essentially almost to normal. So there is potential for upregulation and adaptation that might be successful if your glucose concentration is low for a long time. Maybe that's why Win Tin didn't find problems when Lucas did. Hard to know. Complications of asymptomatic hypoglycemia. So we're going to agree that if you're symptomatic, and the more symptomatic you are, the more likely you are to have problems that should have been corrected and could lead to adverse outcomes. Asymptomatic hypoglycemia remains a bone of contention because there's nobody out there that has been able to show that asymptomatic hypoglycemia is directly associated with adverse outcomes, and no one has shown that treatment of it makes any difference to outcome. So even if a baby has an adverse outcome, there's no evidence that if it were treated, it would have improved outcome. So that's the problem with defining asymptomatic hypoglycemia. That's the treatment, the lack of treatment making a difference. So, treatment, what do we do? Well, we anticipate and prevent. So a key is obviously to figure out ahead of time whether a particular infant might be at risk for low glucose concentrations. We identify that infant, and then we start watching the baby, either by measuring glucose concentrations if the baby becomes symptomatic, or at least preventing problems if we, and you all know what these problems are, so I won't go through them. Those are maternal conditions, diabetes, preeclampsia, macrosomic infants, substance abuse, go on and on. And we could all say that almost every adverse condition known to neonates has been associated with low glucose concentrations, including, as I've already described before, iatrogenic causes. So guidelines for glucose monitoring. State of the art, and I call it art because, as I've already said hundreds of times, the science is limited. Healthy full-term infants, especially those who are breastfed, do not need to have their glucose concentrations measured until they act abnormal. So if they're not healthy in how they act, they don't function normally, then they don't fit into this category. If you have a normal, healthy baby, especially if it's being breastfed, encourage the mother to take good care of the baby. I will bring out that there's now some new evidence, and I was hoping Terry would get into this in her talk, but maybe she'll get back to it another time, because she has the same kind of data, in fact, maybe even better than Frances Cowan and her group in London. But one of the things that's intriguing to me is that if you start looking for things, you find more than what you thought was there. So Frances looked at babies who came into the hospital with significant disorders clinically, including a low glucose concentration. Many of these infants were IUGR, some of them had had seizures, so they were not normal infants. But they did all have low glucose concentrations, and when she did cerebral imaging, she found much more diffuse patterns of abnormalities, including hemorrhage, which had not been associated with hypoglycemia specifically before. Well, just like the Alan Lucas study, these are babies that already had some other problems. So we don't really know whether any of the things that she was seeing on her imaging studies reflected pure adverse impact of just the low glucose concentrations, or a secondary phenomenon such as a surge of blood to the brain from adrenaline in response to a low glucose, which we know can induce a cerebral hemorrhage, at least in very preterm organisms that have poor structure to their blood vessels in their brain. So there's more to look for, and I hope that those who followed on from Terry's talk on imaging will take an issue with that. Here's just one of the usual things. This is one we put together about how you go about treating low glucose concentrations once you have a symptomatic infant or you're following an infant with that is at very high risk. Basically, the numbers are all the same. You start doing something when the numbers get too low or the baby gets more symptomatic, and the more those values get abnormal, or the more abnormal the baby is, the more you move from feeding as a treatment to intravenous treatment. Not very surprising. If that doesn't work, what do you do? Well, almost all of us do what everybody does in neonatal medicine, which is if nothing's working, you give them glucocorticoids. If a baby is not doing well, hydrocortisone fixes them. And we do, that's not true, but that's a sort of a gut response that most of us have. Actually, glucocorticoids are a very useful therapy under these conditions. They sort of jumpstart the liver to produce glucose. They interfere with insulin function in the periphery so that they keep the baby's glucose high. And they enhance glucose release from the liver by activating the enzyme that gets glucose out of the liver. So they make glucose, they produce glucose into the plasma, and they limit its use by insulin-sensitive tissues, so it's available for non-insulin-sensitive tissues like the brain. And the others there are all in sequence of what people often add when simply it's too tough, too hard, you're giving too much intravenous glucose to control the problem. This is the standard approach all of you are using now. It was published quite a few years ago by Rosita Pildis's group in Chicago at the University of Illinois. One thing I would note here is that after only 10 minutes or so, there's no statistical difference between a constant infusion of glucose to correct low glucose concentrations and a primed constant infusion, the mini bolus approach. So this looks like it might be a better approach if you have a baby with potential hyperinsulinism, an infant of a diabetic mother, or a baby that happens to have a metabolic disorder where insulin is being produced. In those conditions, it's the sudden rise of glucose, not the absolute value to which it's increased, that stimulates excessive insulin production. So I think this is a better approach if your baby's not too bad off. Obviously, if your baby's seizing and comatose, I'd get that up right away. Quick and easy guidelines. Here's that value again, keeps showing up. Gets a little lower if you're at risk. All infants with low glucose concentrations and serious clinical signs of encephalopathy require intravenous treatment, no question about it. Target values are higher. So what about this problem of persistent or recurrent hypoglycemia? This is really where the endocrinologists have a point, and we need to find out a way to identify these infants so they don't go home and come back already injured. These are serious disorders. They produce brain damage. There's no question about it. They need to be identified and treated with intravenous glucose until their glucose concentrations are stable, and then advance to both further diagnostics as well as weaning off the intravenous glucose to an enteral diet, and many of these infants are going to respond very badly to any variability in intravenous glucose treatment, so that has to be meticulously controlled. And there may be a way to do that in the future I'll come to just in a minute or two. Try to get insulin concentrations to sort out those that are high insulin versus those that have metabolic defects and fatty acid oxidation or low pituitary problems. These often respond to hydrocortisone and other treatments, and endocrinology consults, to be fair to my colleagues, really should be obtained very early. A retrospective study of a fairly good-sized group, these are not common disorders, so this is a fairly good-sized group, showed that they really had a lot of problems, a significant degree of adverse outcomes. When these are not diagnosed until they're older, mental retardation and even epilepsy show up in increasing amounts. So when not picked up and treated early, the problems increase. What can you say about how to treat them? Try to find these kids. Any baby that's got recurrent low glucose concentrations probably they were obtained because the infant was at risk or had some symptoms. And when you find these infants, make sure that that baby is capable of, on a normal feeding pattern, with a fasting period that lasts a little bit longer than the normal interval of 2 to 3 hours, doesn't have a low glucose concentration before the next feeding. And that probably should be watched for a minimum of a day. Some people will say 2 days. Monitor them frequently, make sure everything is going well, because some babies will simply have intermittent low glucose concentrations and go on to be perfectly normal. But those that are going to have serious disorders, if we don't find them by this mechanism, we're going to miss them altogether. I don't know how else to do this other than saying all babies should, like the endocrinologists say, should have a higher glucose concentration, which is going to totally change how we manage the normal infants. I will say one thing that I've learned both from clinical practice and from reviewing way too many medical legal lawsuits. Beware of the young mother who is trying to breastfeed for the first time with her first baby. She's uncertain about anything and in any way. If she's ill in any kind of way, and if she has limited home support, whether that's family, spouse, or relatives, or people that are coming as visiting nurses. I can't tell you how many of these cases that I've reviewed where the baby comes back to the hospital with low glucose problems, but this was the preceding clinical story. This young mother that wasn't quite ready to do this. She needs help, not told to stop breastfeeding. She needs simply some help, and that's what we should be doing. What about the addition of hypoglycemia to hypoxic ischemic injury? As I've already said, that pathway of biochemical changes that goes on with hypoglycemia overlaps significantly what happens with hypoxic ischemic injury to the brain. Both are involved with reduced cerebral blood flow, producing insufficient brain oxygen supply, and so forth. We could go through the whole metabolic pathway all over again. The point is, low glucose concentrations with low glucose delivery to those cells that have already been injured or are being injured is going to add problems. And that's been studied in animal models and is a very clear story. I only know of one study in humans which actually corroborates that, and it was a retrospective study. So this was done by Jeff Perlman and his group in New York. It was a chart review, 135 term infants. They had a pH in their cord blood less than 7, and 41% were defined as neurologically abnormal. The odds ratio, though, was high for severe neurological damage in those infants with hypoglycemia versus those that did not have hypoglycemia in the presence of these signs of hypoxic ischemic injury to the brain. So initial hypoglycemia, the problem is that that was simply an association, and it fits with the animal data. At the end of the paper, though, a very important statement was made which most people ignore. It remains unclear however, whether earlier detection of hypoglycemia, such as in the delivery room, in this population could modify subsequent neurological outcome. This was a retrospective study. So how many of you would ethically approve of babies who have hypoxic ischemic injury signs at birth and assigning one group to get early IV glucose treatment to normalize glucose and the other one you didn't do anything to? Nobody's ever going to approve that. So I think we simply have to take it that the animal literature is consistent with this, and so you should jump right on babies that have hypoxic ischemic injury signs, assume their glucose could be deranged. It can be high because of adrenaline problems. It could be low for all sorts of reasons. And so you're going to have to manage these babies with very frequent glucose concentration measurements and adjust your IV glucose infusion rates to normalize the glucose concentration. Normalize, well, you could go on and on about what the exact normal range is, but you don't want these babies to continue to have very low or very high glucose concentrations, because in all kinds of studies, both human and animal, very high and very low glucose concentrations on top of ischemic injury, hypoxic ischemic injury, has shown further damage, spreading of the injury. So, what do we do next? Is it time for continuous glucose monitoring? I raise this as a question because it's out there. Some people are using it, at least in research studies, and others are starting to use it clinically. This is data from a group in Spain. This is the first 2 weeks of life. And you can see that not only are there conditions of hyperglycemia that persist, but intermittent hypoglycemia is seen clear out that long. So these are continuously monitored glucose concentrations. It's a small needle that goes under the skin into the subcutaneous tissue. It's measuring subcutaneous interstitial glucose concentration. Interestingly, the correlation with plasma glucose concentration is very tight. It's a pretty good measure, and that occurs despite variations in obvious changes in what looks like skin blood flow or skin perfusion. Most of these studies in small babies have not shown problems with infection, bleeding, or if there's a needle hole left over, wound healing. So the usual things we worry about don't seem to show up. But clearly, they're defining a lot of problems that continue for a long time if you think low glucoses are significantly worth following. So, why should or should we not do this? Well, there's no information about the clinical significance of episodes of low interstitial glucose concentrations and which, if any, should be treated or in which infants. So that's the exact same problem we have now. It's just that it's going to come up more frequently. And so I look at this very much like pulse oximetry. Pulse oximetry was added in the early 1980s as the 5th vital sign. Every baby gets pulse oximetry values. But I don't know of a study that has shown that it's improved outcome of any kind. In fact, the only study I know of, Terry already mentioned, which was that if you have a problem with too high in oxygen or too low in oxygen, you probably could have a difficulty. But you knew that already. So the pulse oximetry hasn't changed anything, and it's just as likely that more frequent measures of glucose are just going to add more data, because we still don't know what any one of those values means unless we set up a study with an intervention where one group, those values are ignored, and the other, somebody corrects them to a predetermined value. So which glucose concentration and of what duration should be used as the lower subcutaneous threshold, just like the lower plasma threshold? Same old problem, just more often. And so there's a danger that continuous glucose monitoring might be incorporated into clinical practice without clinical assessment and research assessment. This might result in all kinds of babies. I worry mostly about normal, healthy breastfed babies who have lower glucose concentrations naturally, getting treated when they shouldn't be. There's lots of pathology that's associated with simply IV treatments of babies. Equally, there's problems with attachment of the mother and breastfeeding. Glucose monitoring we need studies to clarify relationships between continuous glucose concentrations, symptomatic hypoglycemia, response to treatment, associated medical conditions, and neurodevelopmental outcomes. And the importance of such studies must be balanced with the delay in implementing new technology and its potential to uncover glucose concentrations that ought to be treated that we hadn't found earlier. I'm going to skip to one controversial figure. This is the new American Academy of Pediatrics Fetus and Newborn Committee guidelines for infants at risk. These are infants who are either late preterm infants, 34 to 37 weeks, term SGA infants, term infants of diabetic mothers, and term large for gestational infants. All they did was lower these values a little bit. And this has caused a huge amount of controversy in the United States because there are a lot of pediatricians out there who are afraid of lawsuits. And they have no rational basis because this figure, these data, and these guidelines had the same background that I've already talked to you about, which is we don't have the rational data to go along with that. I just be cautious about interpreting low glucose concentrations as you see them as causative of later neurodevelopmental disorders, and encourage all of you to say, if we don't know that for certain, there's still plenty of opportunity for research. Thanks very much.
We used to